Hello, today we will discuss pachymetry, specular microscopy, keratometry, and the fundamentals of corneal topography. Because of the complex nature of the eye placed on a small sensory organ, ophthalmologists rely on a number of sophisticated equipment to evaluate various ocular structures and measure their functions. It is therefore part of an ophthalmologist's training to understand and acquire the skills needed to discern and interpret these images and measurements properly and accurately. So let's talk about pachymetry. Okay. So before we learn any of this, what's important for all of you is to know, well, what is normal? Okay. So the thickness of the cornea, whether thick or thin, can provide an insight into the general health of the cornea itself. And whenever possible, pachymetry should be correlated with refraction, vision, and IOP. First, let's talk about slit lamp biomicroscopy. Okay, I recently gave a lecture on this. Okay, and so slit lamp can be used to determine thickness of the cornea. Okay, although it's very subjective. As you can see here, the picture on the left will show you a relatively thin or normal cornea, and the picture on the right, based on the slit, will show you a relatively thick cornea. Okay, you can also measure corneal thickness, okay, or pachymetry by using the old machine called an optical pachymeter. Okay, the old optical pachymeter, okay, which was attached to a slit lamp, quantifies corneal slit thickness. This is no longer used. Okay, for many years, the gold standard that was used in measuring corneal thickness was an ultrasound pachymeter. Okay, wherein sound bounces off the Descemet's membrane. And the problem with this was that it was invasive, okay, because it involves contact with the cornea. And of course, there's rough localization. It's just that where you point that ultrasound pen, you'll get the thickness, but it doesn't really tell you exactly what part of the cornea. And so the repeatability was not also that accurate. Today, the gold standard for measuring corneal thickness or corneal pachymetry is a scanning slit or a Scheimpflug imaging. Okay, this is the gold standard used for refractive surgery. Okay, it's able to measure the thickness of the entire cornea and automatically measures and locates the thinnest point of the cornea. Okay, you can also use an ocular coherence tomography to measure corneal thickness. Here you can visualize and measure different layers of the cornea, but it's only seen in a 2D image like you can see here. Okay, and it's usually not just used for corneal pachymetry. Usually, ocular coherence tomography is used for other things like retina, okay, and or glaucoma, but rarely for the cornea. There are other machines, specifically some biometry machines, that use ocular low coherence reflectometers or OLCRs, okay, and it measures thickness at the point of fixation, usually on the central part of the cornea. Okay, and of course, there are also corneal biomechanics analyzers like the oculizer or the ocular response analyzer, okay, which measures corneal hysteresis, basically how soft or rigid your cornea is, can measure the IOP of the eye quite accurately, and it can measure pachymetry usually centrally at a very fixed point. And your specular microscope can also measure thickness of the cornea. Okay, it provides corneal thickness at the area measured for cells, and it can interpret and correlate cell density and morphology with the pachymetry. So there are many ways to measure thickness of the cornea. What are the common applications for pachymetric data or the data for the thickness of the cornea? Most common, of course, is used for screening for refractive surgery eligibility. Okay, so nowadays we don't do LASIK or PRK without knowing how thick your cornea is to see how much treatment can be applied to your cornea. That's the single most common application for corneal pachymetry today. Less common now, or second to refractive surgery screening, would be diagnosis for various corneal pathology. So usually when you have thick corneas, we will think of certain pathologies that lead to corneal edema like Fuchs dystrophy, Or if you have thin corneas, we would tend to think of corneal ectasias like keratoconus. And of course, measuring the corneal thickness or pachymetric data helps us confirm these diagnoses. Pachymetric data is also used for monitoring the health of a corneal graft. So usually a healthy cornea is a thin cornea, a clear cornea. But then when we see that corneas are progressively getting thicker, then we might begin to question whether that graft is still viable long even before that cornea becomes cloudy or opaque. And of course, knowing how thick your cornea is helps us assess the true intraocular pressure of the eye. Let's talk about specular microscopy. So specular microscopy is the quantitative and qualitative assessment of the corneal endothelium. Okay, it measures cell density, cell size variation, cell shape variation, and corneal thickness as well, like we just talked about. Okay, so there are both contact and non-contact types of specular microscopy. Now, if you remember the lecture I gave on the slit lamp biomicroscopy, where you have specular view, okay, specular view is a kind of specular microscopy only in a very magnified and digitalized way of assessing the cells. So you need to have the viewing arm at a particular angle and the light source at another so that you can view endothelial cells. So you need to know what's normal, okay? What is the normal corneal endothelial density, okay? So usually we are born with about 350,000 cells for the entire cornea. At birth, that density is around 3,000 to 4,000 cells per millimeter squared. When we're about middle age, that reaches about 2,500 or 2,500 cells per millimeter squared. And at old age, that'll be about 2,000 per millimeter squared, okay? Minimally acceptable before our cornea begins to decompensate is about 1,500, okay? And of course, we will get potential corneal edema at 800 or even less. So normal endothelial cell count or normal. So if you look at the image on the right, you will see that your cells are hexagonal in shape. They're technically small, okay, and they're compact altogether, okay. A low endothelial cell count will cause your cells to become larger, okay, and so the size of your cells tend to enlarge to cover the same space that the whole cornea is. So your endothelium has to cover the entire space of the cornea. So with lower counts, you will get larger cells. Okay. Now, polymegaphism, okay, is the variation in cell size. Okay. So, or the coefficient of variation. So in a young adult, the normal values would be 0.27 or 0.28, or the convention we use is just 27 or 28, okay? Normal values are pegged between 22 and 31. So basically, your cells have to be in uniform in size, okay? So when you have a variation, or you have some big, some small, okay, then we will call that coefficient of variation, okay? Polymegaphism. Pleomorphism, you have a variation in cell shape. Okay, the typical cell shape of your endothelial cell is, of course, hexagonal or 6 sides. When you get a variation of that, where some will be 5 or 4 or 7, then that we will call that pleomorphism or variation in cell shape. Okay, clinically significant if your variation is less than 50%. So as long as the hexagonality is 50% or more, then we will consider that as normal pleomorphism. So if you look at this distribution of cells in this diagram, polymegaphism is when there's a change from uniform cell sizes to variable cell sizes, and this is an indication of distress to the endothelium. Okay, pleomorphism is a change from optimum hexagonal cell geometry to variable compromised cell shapes, as you can see here. Okay, so it's important that you don't just focus on cell density. Many eye practitioners will just focus on the cell count, whether it's 2,500 or 800 or 3,000. Okay, but you need to focus also on normal cell, on pleomorphism and polymegaphism. Okay, A cell count without cellular morphology statistics may be misleading. For example, okay, let us look at Goutte. Okay, Goutte will tell you, okay, this is particularly typical of Fuchs, wherein you have large spaces, okay, and you will have loss of count, and you will have different cell sizes and shapes, as you can see here on the picture on the right, okay. But in this picture where you have polymegathism, okay, you have different sizes of the cells and different shapes, but look at the count. The counts are very high: 3,268, 2,967, 3,121, and yet you have polymegathism, okay, and or pleomorphism in these pictures, not just like in Fuchs. So this is a sign of a cornea in distress, and in this case, this is an example of somebody who overwore their contact lenses, and so the cells become stressed because of lack of oxygen. So what are the common applications for specular microscopy? Okay, well, surgery. Okay, pre-op evaluation for cataract or intraocular surgery is a common application for specular microscopy, especially if you use premium lenses. Usually we know that surgery will cause a drop in endothelial cell count. And so as cataract surgeons, you would want to see whether you have adequate cells, okay, to make sure that your cornea will remain clear after surgery, okay, or whether the indication for keratoplasty or post-keratoplasty follow-up, okay. So you want to see whether there are enough cells for you to just postpone corneal transplant, or whether your patients will need corneal transplant soon, okay. Specular microscopy is also used for the diagnosis of certain corneal pathologies, okay. It's also used to correlate with clinical assessment of the cornea, and for research and evaluation of safety of medications and devices. So, for example, whenever they evaluate new devices like new intraocular lenses, new IOLs, okay, all patients are sent in for specular microscopy because there have been some devices which cause a higher attrition rate of endothelial cells compared to others, which render those devices unsafe. And so it's very useful for evaluation of certain devices in research in ophthalmology. Let's talk about keratoscopy, keratometry, and ultimately topography. Okay, so keratoscopy is a subjective examination. Okay, in terms of the shape of the cornea. Okay, it can aid in the direction of a corneal impression diagnosis, but there is no quantification. So here, what you can see are just reflections of rings onto the cornea, which tells you more or less whether this patient has astigmatism or no astigmatism. Okay, but you can't measure it. It just gives you an idea. Okay, so there were used to be, not anymore, actual keratoscope measurements. Okay, and sort of what this image tells you is that lines that are closer together denote corresponding steep areas, and lines that are farther together would mean that areas of the cornea are flatter, pretty much like a topographic map of the mountains, if you've ever had the opportunity to see some of those. Okay. Now, keratometry. Okay, you have probably seen a keratometer, okay, or perform keratometry. Okay, so when doing keratometry, the examiner is presumed to be emmetropic, no, either walang grado or you're wearing your glasses. Okay, there needs to be alignment of the visual axis for both examiner and the patient to the keratometer. Okay, you need a well-lubricated cornea without artificial changes in the curvature and size of the reflected images. And you need to have attention to Meyer centration. The image is properly focused and the values are recorded. And it would be optimal if the refractive index of the keratometer is the same as the cornea, 1.3375. Okay, so there are several types of keratometer. The more common one is the one you see on the right, which is the ophthalmometer, which is a branded name by Bosch and Long. But there are other keratometers like the Javal keratometer, as you can see here on the left, the white one. So in the Bosch and Lomb keratometer, which is the image on the right, you need to align the Meyers, which is the plus and minus signs, and you need to align the axis by aligning the circles more into a reverse L shape, unlike the picture shown here. In the Javal keratometer, same thing, you need to align the red image and the green image pretty much like the picture on the right. So you need to correlate findings whenever you measure for keratometer, okay? For any K readings in any meridian less than 40 or more than 47, please repeat the readings. I mean, it can very well be that the cornea is 48, but then by that time you would be suspecting some kind of corneal ectasia. So if it's beyond extremes of measurement, you might want to repeat it, okay? Please correlate with the oldest available refractive error and or axial length. And if the average corneal power between the eyes differ more than 1 diopter, please repeat just to make sure, because you don't know whether that error is from the person who took the test, okay, or if the eyes are really anisometropic. Okay, so is there an appropriate amount of corresponding anisometropia? Okay, if the astigmatism for either eye, very high, is more than 4 diopters, please repeat. Okay, you never know whether there's an error in your reading or if the eye is really, really very astigmatic. Okay, and you need to confirm this against the manifest refraction or obtain a corneal topography just to correlate the findings. Okay, now when do you repeat? Okay, for poor fixation, determine if there's poor fixation if it's because of a mature cataract, a macular hole, or others. Okay. If patient fixation is not possible, align the keratometer reflex at the pupil center. If the pupil, however, is eccentric, align it at the corneal center. For problems with patient cooperation and or understanding, bring back the patient and try again. Never ever accept an inadequate measurement. And this is true for all of the numerous instruments you're all going to use in ophthalmology. Never accept an inadequate measurement. Okay, and that's why it's important that all of you learn how to get the measurements for all the machines you're going to use, because at the end of the day, okay, you're responsible for your patients. Never rely on what the technician gives you. Always make sure that it's an accurate measurement. Okay, now what are some guidelines? Okay, discontinue contact lens wear, okay, at least 2 days before taking a measurement, or 2 weeks if it's hard contact lenses. This will prevent masking of astigmatism and undetected central corneal flattening. Get the reading within 5 seconds after the last blink or before the breakup time. You may use BSS to wet the cornea, but do not use artificial tears. Okay, and use corneal topography for unusual readings and or poor quality wires. This will help uncover unusual pathology, such as a previously undetected keratoconus. Okay, let's talk about topography. Okay, and topography has several names. You can say corneal topography, you can say video keratography, they mean the same thing. And what topography does is that it scans, quantifies, and qualifies the entire corneal surface or shape. Okay, and this can be done 2 ways. It can be done through a Placido ring-based, like a keratometric map, or a Purkinje image-based or an elevation map. Okay, and this Purkinje-based can be either done using a scanning slit or a rotating Scheimpflug, and we will discuss each of these. So when you look at this picture on the left, where you see a cornea, and there are reflections of rings in it, okay, or you can have a slit going through the cornea, and it'll also give you an idea of the shape of the cornea. Okay, so the one on the left is a precursor to a Placido-based image, and the one on the right is a precursor to an elevation map-based kind of topography. So remember, I showed you this picture, which were keratoscopy rings. This is the basis for a Placido ring-based topography. Okay, so how does it work? You have a keratoscope image, wherein the machine will digitize the rings, it will calculate power and location, and it will display a map like this. Okay, so here you'll see obviously a corneal ectasia, okay, and like a pellucid marginal degeneration, and you can see how it correlates with the Placido ring images below the maps. Okay, here is a typical Placido ring topography of a normal cornea. Okay, so I know we are drawn to the color and you are drawn to see that it's normal, but make sure you take a look at the numbers. So here it says the steep K is 43.84, the flat is 43.3. So you have a very minimal astigmatism of 0.5 diopters at a particular angle. Okay, and so when you see an even colored picture like this, then it shows you that it's a normal cornea. Okay. Okay, it'll also show you in this other axial view a certain hourglass picture. Okay, so here it shows you the steep case 45.25 and the flat is 42.92, giving you as an astigmatism of 2.33, which is a moderate amount of astigmatism. So when you see the upright figure of 8, okay, then you will more or less denote that this is a with the rule astigmatism, where the steep meridian, again, I repeat, the steep meridian is superior inferior, okay, and the flat meridian is around the 180 axis, okay. Don't worry, this gets more confusing, okay. So in a placido-based map, an upright figure of 8 is a with the rule astigmatism, okay. Now in topography, okay, before you interpret, okay, you need to know what is the image quality, whether your astigmatism is regular or irregular, and if the values are within the normal range. Okay. For each ring, a certain number of points are identified, usually 5,000 to 20,000 points. Most topographers now are 20,000 points or more. So even placido-based topographers, which are less in use now, are very, very accurate for the corneal surface with 20,000 points or more. Okay. Okay. Do check the color-coded maps. Okay. But you need to check the scale. Okay. Is the scale only by very fine, by 0.25 diopters, half a diopter, or 1 diopter? Large increments will make an abnormal cornea look normal, and small increments may make normal cornea seem abnormal. And you have to check how the map is oriented over the pupil. So for example here, okay, again, this is a placido-based map. There's a figure of 8 that's on its side, okay, and so this is an against the rule astigmatism, okay, again, against the rule astigmatism. You can see there's a very high amount of astigmatism, 4.22 diopters, okay, that's why there are a lot of colors flashing here, okay, even if the scale is only by 0.25 diopters. Now, when you see this in your maps, when you have dots, like in the picture on the right, okay, or empty spaces on the left, okay, that means there's inadequate data, okay. Dots will show you that data is interpolated by the machine, okay. So never accept these kinds of readings, okay. If you see this, have the image repeated. If you are forced to interpret this, okay, it'll still end up being very inaccurate, okay. So just to avoid any trouble, just have the reading here repeated, because obviously they were only able to scan, okay, at least half or a little bit more than half of the entire corneal surface. Okay, now here, when you look at this cornea, wherein you see that the center is flatter than the periphery, okay, usually a normal cornea is prolate, where the center of the cornea is steeper compared to the periphery, which is flatter. But when you look at these images, you see that the center is flatter compared to periphery. And these are post-LASIK, myopic LASIK ablations, okay, where they laser the center of the cornea, so the center of the cornea looks flat compared to the periphery. Okay, so here I can tell you that this is more or less a post-LASIK or post-PRK patient. In some images or some maps, you'll also see squares, okay? And so each square denotes 1 millimeter. So here you can also measure the total cornea. So here I can measure 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. So this is an 11 millimeter cornea, more or less, no? If you can count those lines. So it tells you more or less the orientation and the size of the cornea. Okay, now if you look at this placido-based map, which is an axial map, you can see that there's a very steep curvature inferiorly, okay? So here it says 51, okay, and then the flat case 45, but you can see that it's irregular, okay? The difference between regular and irregular cornea is that a regular cornea means that the steepest meridian is 90 degrees away from the flattest meridian. So what is irregular? What is an irregular cornea? When it is not 90 degrees. So the problem is with this topographer, it'll still show you 90 degrees difference, as you can see here. But you can see in this map that it's not 90 degrees. These are very highly irregular astigmatic cornea. And so this is what keratoconus looks like, okay? Now, some machines will also denote differences. For example, here you will see the circle here will show you the center of the pupil. This circle here denotes the pupil, and the triangle here will show you the steepest part of the pupil, of the cornea, okay? And so different machines with different softwares will have different capabilities as well. You will also see in your cornea readings with the Placido, sometimes what we'll call axial or sagittal reading and or tangential. So take a look at this, okay? So this is the same eye between sagittal and tangential. So this is a normal eye, axial or sagittal, and the same eye will show you a tangential reading, okay, which looks like it's irregular, okay? Here's a keratoconus eye, axial, and then here's a keratoconus eye, the same eye, in the tangential medium. So what does this mean? Okay, so when you assess this, okay, a sagittal image on your topography uses a central reference for the entire eye. Okay, so everything is measured against a central reference, and so sagittal curvature or axial gives you a good sense of the overall power of the cornea, but it's very weak in picking up fine details on the surface. A tangential curvature map uses each bump in the cornea as a reference, and so this is better in measuring fine changes in the surface of the cornea, particularly in the peripheral part of the cornea. So again, what's the difference? Axial or sagittal will give you an overall sense of overall curvature. It's less sensitive to noise. It's less accurately peripherally, okay? In a tangential curve, okay, it measures local curvature. It's most sensitive to abrupt changes in the cornea. It can detect subtle changes, and it's more sensitive to noise, and it's more useful in healing trends. So you need to know when to use or when to request for each of these maps. So if I'm looking for a certain healing in the cornea, I might perhaps request for a tangential map, okay? But if I'm looking at more or less like refractive surgery, where I want to know the overall power or sense of curvature of the cornea, then I will request for an axial sagittal. But when your patient undergoes topography, both images are automatically taken anyway. So it's not that the patient will have to go back for a tangential if it missed it. You will always have both images available in the computer. Now, to confuse things further, but which you need to know, is we will now talk about elevation topography, okay? So elevation topography talks about the corneal shape in reference to a reference shape. So for example, in this image, the yellow part here refers to the cornea against a particular shape, which is the green or a sphere. So you will see that some parts of the cornea will be below the reference shape, and some parts of the cornea will be above the reference shape. So if you look at that, okay, parts underneath the reference shape will give you blue, like water, and parts above the reference shape will give you orange or yellow or red, which is above the water. So here a normal cornea is prolate, okay, meaning that the curvature decreases from the center to the periphery or steeper in the center. And so this is what elevation topography is all about, okay? So elevation topography can evaluate both the anterior and posterior corneal surface shape. Okay, this is something that Placido-based topography cannot do because it's just based on the reflection. Okay, it can only determine or measure the anterior surface of the cornea. Elevation topography can measure both the anterior and posterior corneal surface. Okay, it can measure corneal thickness because it can measure both surfaces. It can measure corneal thickness along the entire structure. Okay, and of course, it relies on a reference shape, usually a sphere, but there are other shapes too. Okay, and it is now the gold standard for corneal topographic measurements. Okay, so this is the orb scan, okay, which is the gold standard for many years. Okay, So remember how I told you that an hourglass shape will show you, an upright hourglass shape will show you a with the rule, okay? In elevation topography, this shape now converts. So this is a with the rule astigmatism kahit na nakahiga to, because it shows you that here, this is under the water or under the shape, and then this bridge you see, the yellow, okay, is over the shape, and the green tells you that it's aligned with the shape. So you can see that the steep meridian here is the 90-degree meridian, and so this is with the rule, okay? And this is the anterior corneal surface, and this is the posterior corneal surface. So you can actually measure both, okay? And then there's a keratometric. This one sort of tries to interpolate it the way a Placido measurement will render it, okay? And of course, the beauty of this is that it can also show you thickness of the cornea at any of the points along the entire cornea. And so this is the great advantage of elevation topography. Okay, here's a pentacam, okay, same thing. So what you would have thought would have been against the rule in a Placido-based topography, here this is a with the rule, okay? So that's why you look at this. This is the elevation map. It shows you a with the rule. And then this is the keratometric rendering or the Placido-based rendering. Okay, it's with the rule. You can see that the figure of 8 is upright. Okay, again, the posterior float or the posterior map. And then, of course, it will show you thickness again for the elevation map. Okay. Now, the pentacam is based on Scheimpflug technology, wherein you'll have several of these images that will rotate along particular axes in the cornea. And so if you combine all of these images, you will come up with a tomographic image, like a CT scan, no? Computed tomography, okay? And so if you take this at particular axes, it will come up with a particular shape. So the red is the anterior cornea, the green is the posterior cornea, the blue is the iris, the yellow is the lens, okay, as you can see also here. So this machine can come up with a rendering, okay, of what the anterior segment would look like. And of course, it can come up with detailed maps of the cornea as well, for like in topography, okay. And so again, these are pictures of a pentacam. You can see that this is fairly normal. You can have the distribution of thickness and the distribution of the keratometric values here, okay. So what are the common applications for topography? Okay, number one, the screening, evaluation, and follow-up of corneal refractive surgery patients. So think about it. If over 30 or 40 million people have had LASIK or PRK, then 30 or 40 million people have had this kind of test already. Okay, very, very useful. Okay, it's used also in the evaluation and diagnosis of corneal ectasia. Before, this was the number one indication, but there are nowhere as near corneal ectasias as there are who have LASIK, right? And so now the common indication is that of having refractive surgery. Okay, you can also use this for confirmation of other diagnostic modalities like keratometry. Okay, and of course, you use topography for challenging contact lens fitting. Okay. Again, as with keratometry, you need to validate the results. You need to correlate it with the refraction. You need to correlate it with other modalities like your keratometry. You need to repeat scans if they're not acceptable, not just one. You need to correlate the two eyes, okay, right with left if possible. And if you have the data, you need to correlate with previous maps to see whether there's stability or there are changes. And with that, I thank you for your attention. Have a good day.